Hello, I'm Locke Meredith. I would like to invite you to the next show. We have a great guest, Dr. Barrett Johnston. He's a pain management doc, board certified in pain management and anesthesiology. He's going to talk to us about the typical type of pains that he treats, whether it's in the head, neck, back, hip. And he's going to talk about some really unique ways to treat the pain. Of course, you have the various injections, but he also has new techniques that are basically an internal TENS unit that kind of shocks the nerves so they don't cause pain. A lot of other options, but it's a great show. So join us on the next Legal Lines with Dr. Barrett Johnston. Legal Lines has interviewed Louisiana Supreme Court justices, appellate trial court judges, federal, state, and local government leaders, including U.S. senators and Congress members. Watch at Locke Meredith, Sean Fagan & Associates website, LockeMeredith.com, or Cox Channel 1004.
At Locke Meredith, Sean Fagan & Associates, it's an honor and a privilege if you choose us to serve you.
We serve you with respect, dedication, and an unwavering commitment.
We serve you by working hard and striving to get you the best possible results.
We serve you using 60+ years of legal knowledge, experience, and relationships.
At Locke Meredith, Sean Fagan & Associates, we believe that life is about relationships, and it's the mission and ministry of all of us to serve you. Locke Meredith, Sean Fagan & Associates has served our community by airing Legal Lines, a community educational program for 18 years weekly to Baton Rouge and the surrounding areas. Watch Legal Lines at LockeMeredith.com or Cox Channel 1004. Hello, welcome to Legal Lines. I'm Locke Meredith, and I'm very pleased to have on the show for the first time Dr. Barrett Johnston. He's a pain management doctor and a doctor of anesthesiology.
Hey, good to see you.
Thank you for doing this. I'm looking forward to it. Most folks don't really understand kind of what you guys do. And frankly, in a lot of ways, the pain management world, you know, media's tearing them to shreds, acting like you guys are a bunch of criminals or dope pushers, and that's not true.
Not true at all. So I'm glad to be here. Thank you for having me.
I've been treated by them and by you, and it provides a ton of help. So I want to thank you for your chosen profession.
You're welcome.
But tell the folks a little bit about yourself. Why do they care what you think or say?
So I grew up in New Orleans, right on the West Bank. Kind of grew up there my whole life. Went to college in California. Came back to Louisiana. Went to LSU for med school. Then went away again for Harvard for med school and residency. Did an anesthesia residency background, so I kind of got to know that. So
you're 5 years at Harvard?
4 years at Harvard, another year at LSU, but I did anesthesia there as well as a pain fellowship there. So I got board certified in both anesthesia and pain management. And then now I just specialize in 100% pain management here. Moved back in August 2011. Have family, I have 4 kids. My fiance has 3 kids. So
you got a full house, dude.
Oh, it's a good time. It's a lot of fun.
4 kept me busy.
So I managed to work a little bit, is what I'm telling you. And so, but I have a great time just treating the community here in Baton Rouge.
Well, and the folks, I bet a lot of folks have heard of your dad, Alan Johnson, who's been a great orthopedic surgeon here in Baton Rouge for decades.
Yep. And he's been a hero of mine and somebody I've looked up to my entire life. And he's, as you said, an orthopedist here in Baton Rouge, right down the road on O'Neill Lane. So.
Yep. I actually taped a show with your dad, I don't know, probably 10 years ago. He's a great guy. And, you know, you're following in big footsteps.
Oh,
but
big shoes to fill.
Based on my experience, you're doing great. So why did you decide to go into this?
So I kind of got into this through the field of anesthesia, and we did a rotation in pain management. And I think pain, like you mentioned in the start, is a very misunderstood field. People think that the person's in pain, and because you can't see it, you can't run tests in a lot of ways to say the person's in pain. They're misunderstood as they just want medications, or they're just trying to get out of work or get some kind of benefit, when a lot of times people are just hurting. And pain will impact the person's psyche, their family life, in every aspect.
Shut you down.
And so for me, when I did that rotation and I saw the benefit that a real pain doctor can give somebody's life in every aspect, I said, this is perfect. Because I've always kind of been a leader and didn't mind being outside of the cool group. And so I don't mind putting myself out there and doing pain management. And
well, it's interesting too, because, you know, I looked at your CV, you have some amazing accomplishments and awards for leadership, and the president of your student body and many other recognized positions. So,
yes, sir. I've kind of always been okay with putting myself out there and standing up for what I thought was right. And so I think pain management, especially today's age, really needs some leaders like that, because we are being attacked from every angle. Everybody does not get narcotics. We are looking for ways to treat the pain. Sometimes it is appropriate, but there are many other ways to treat pain.
Well, and truthfully, just in my lifetime, and since I've had 2 back surgeries, one on the left, one on the right. You did the block, thank God, when I had the right side blowout on me in February, and it enabled me to survive another week, frankly, before I could have the surgery. And it's incredible the new tools that y'all have to treat pain that didn't really exist when I started practicing.
Yes, there is so many options besides standard. So I kind of tell patients there's 5 things we can do. We can just work through it and you learn to live with it. You can do medications, physical therapy, injections, and surgery. Well, so now there's newer injections and types of injections. There's newer surgeries from a pain management standpoint that don't require fusions in some of the bigger surgeries, or that are appropriate once those have been done just to manage pain. And even though some of the techniques are the same, the technology has gotten better and better to where we're really getting great results today.
It's fantastic. So tell me what you're generally seeing in your practice. You have a very large practice. You deal with a ton of patients a day. And you're changing their lives in a lot of ways, in a positive way, in my view. So describe what you're seeing in your practice.
We literally see every type of patient. We see patients who have been in accidents, whether it's motor vehicle accidents, work-related accidents. Those are more acute pains, which we'll look to see what changes there are in MRI, and we'll address those specifically. We see the older patient population who have more degenerative changes in their spine, which
Explain to folks lay terms, degenerative.
Degenerative meaning, so the disc, or if you were to look at the spine model here, these discs are cushions in between the bones of the spine. And as you age, they'll lose some of that cushion and fluid in there that makes them soft and spongy.
Like a shock absorber.
Exactly the same. And so they become harder. Well, as those collapse, they can cause bone spurs and collapse the space here and cause stenosis and pinched nerves.
And the bottom line is that happens just because your body's aging, right?
That can happen just as you age. Now, some people
We both used to have hair.
Yeah, unfortunately, yeah.
Things happen.
And so, unfortunately, that's something that will happen over time. Some people's faster, some people's slower. And there's things we can do for that you're going to be treating that person for a long time. Whereas more acute injuries, you hope to get them better, back to their previous quality of life, and hopefully you don't see them the rest of their lives.
And when I was kind of reviewing, preparing for this, your practice, it looks like, frankly, you deal with problems with the head in terms of migraine headaches and such, neck injuries or ailments or illnesses as it relates to the spine from the top all the way down, and all the symptoms that can be caused into your upper and lower extremities, arms, legs.
Yes, sir. So most of our practice is, and I say our because it really is teamwork. I have 3 physician assistants, several nurses, and so everybody's involved with patient care. So that's why we'll refer to ours, but I am the only physician there. We mostly see spine pain, but we do treat migraines, facial pain, abdominal pain, rectal pain, ankle and joint pain.
I even saw cancer.
Cancer pain we see neuropathic pain. Every type of pain we'll treat. Sometimes we will refer those out to other specialties if need be, but we're comfortable seeing and treating anything, at least to start.
Okay. And so you kind of outlined it earlier. First, kind of the typical course of treatment is what they call conservative, which is meds and physical therapy and stretching and whatever, which doesn't always work. And then you kind of kick into the minimally invasive with the shots, basically.
Yes.
Bigger needles, a little more medication here and there.
That's right.
But you got to get to deeper spots in the body, right?
Yes, sir.
And then the third kind of big category is the whole, well, in a weird way now, though, like you were discussing, technology-wise, you have new tools.
Yes.
Where normally you would have gone straight to surgery, you have some more, maybe a little more invasive, complicated, but it has introduced a whole new way of treating folks.
Yes.
So tell folks about, first of all, let's talk about the injection litany of tools that you have.
So I want to go back to Medicaid one second. When we talk to medications, I want people to realize we're not talking about just opioids, because there's an opioid crisis now.
Yep.
When we talk about medications, we're talking about non-narcotic medications, anti-inflammatories.
Muscle relaxers,
We look
all
at
that kind
all
of
those
stuff.
first before we go to opioids. So just to be clear.
Because opioids doesn't fix anything, right?
No, in long term, they really are not a great option. So injections nowadays, there's epidural steroid injections that go into the epidural space, which is, if you were to look at the spine, is the space here between the spinous processes.
We'll make sure the camera can get this.
Can you see that? Okay, I'll move a little closer here. And so that would be this space here. You can also get to the epidural space using a foraminal approach that way. That would treat disc disease, pinched nerves, stenosis. Facet disease here, which would be your ablations and medial branch blocks, would be an option here. You can do some other muscular injections of the spine, SI joint injections. And so some of these are kind of the common things we do that we would look at doing first that have been around for a while.
Okay. And I tell you what, on the next segment, I want you to describe to folks what the function is of the spine, how it works, and what are the parts.
Absolutely.
So we'll be right back. This is Locke Meredith Legal Lines, and my guest, Barrett Johnston, pain management doctor, anesthesiologist. We'll be right back.
Hello, my name is Collins Meredith. I'm one of the attorneys here at Locke Meredith, Sean Fagan and Associates. One of the many distinguishing factors of our firm is that we are not just one lawyer that you are hiring. We are a team of attorneys. When you hire one of us, we all pull from each other's experiences, knowledge of the law, so that we get you not only a solution to your problems, but the best solution that we can come up with for your problems. So for that reason and many others, I hope that you hire our firm.
Hi, my name is Mitchell Meredith. I'm one of the associate attorneys here at Locke Meredith, Sean Fagan and Associates. One of the reasons I love this firm is that the moment you walk through the doors, you're so much more than business. You're family, which means we're going to fight for you as if you're family. At the end of the day, I think what distinguishes our firm from others is we're a firm that is truly personal, professional, and proven.
Hello, welcome back. I'm Locke Meredith. I'm pleased to have on the show for the first time Dr. Barrett Johnston. He is a medical doctor of anesthesiology and pain management. Thanks again for doing this.
Thank you.
Let's dive back in. Okay,
Yes.
You were kind of explaining to folks the different points on the spine or the structures where you could help alleviate pain. Can you describe in more detail the structures and what exactly it is, that the function of that?
I sure can. So this would be the patient's lumbar spine or their lower back portion of the spine. So the buttocks would be here, the abdomen's the front part here. And so you have what actually patients feel, if you were to feel back the spinal
Right.
processes, those are the bumps right here. Sometimes people think there's a disc, but it's actually the bones right here.
And that's what the ligaments and muscles and tendons attach
everything
to?
attaches right there.
Okay.
Your disc are actually these blue discs here, they're cushions in between the bones, which are vertebrae. And so it goes a vertebral bone, disc, all the way down till you get to the pelvis, which is a sacrum. These discs are basically just cushions. And they
I've
create space.
heard it described like a jelly donut.
It is like a jelly donut because there's jelly on the inside and that doughy outer fibrous part that keeps the jelly in there. And that'll be important in just a second. Then on the back side of the spine, you'll see, if this was a solid bone, it would all be solid. You wouldn't have any movement.
So
they
the
have
cushion
joints.
and what you're about to talk about, they allow the mobility.
Correct. And the joints allow mobility. If you didn't have that, there'd be no movement.
We'd
You'd
be all
solid.
walking like
Correct.
this.
You'd be stiff. And so what we'll treat sometimes is you can get, these can be degenerative where they get shrunken down or dried up. They can bulge back. A bulging disc is similar to that jelly donut analogy we did a second ago, that doughy outer part bulging, but it's still intact, versus a herniation where the jelly has squirted outside the donut.
Outside the crack.
Those are
right?
the two. And what happens is, you can see, there's not much space there. And so if that's bulging into the canal, then it's going to irritate those nerves, and that's how you get pain. That's sciatic pain, which is pain down the leg.
And the yellow coming out, that's the nerve root?
That's the nerve right here. This is your
Okay,
nerve
so
root
that's
coming
the
in.
nerve. And then the thicker cord in the top that runs all the way down.
That would be your spinal cord.
Oh, that runs from your brain down to every part of you.
Yeah, and it branches
Via the
off.
nerves.
It's really a bundle of nerves, and as it gets further down the spine, it branches off into they call it a horsetail, but little nerves that kind of branch out. And so then the joints here can get arthritis, just like other joints, such as the knees and the shoulders. And so we can do blocks to treat that as well. So what we'll typically do for disc pain or nerve pain, we'll do things like epidural steroid injections, which is a steroid shot through this approach or the lateral approach, and that would treat some forms of back pain or pain radiating down the legs.
Is it reducing inflammation or swelling or what?
Both. Inflammation is swelling, so it does that, and it will allow those nerves to kind of heal themselves and
They
kind of
chill out?
recover. Exactly.
Okay.
And so it may take one, it could take a couple, just depending on how the
Is there a
body responds.
regulation on how many you should have a year?
You can do in the beginning a series of about 3 of them a month apart. Then you need to spread it out to about every 6 months. Because
Okay.
steroids, although they have some great healing properties, too much can weaken the bones and cause some other
Now, are
issues.
they typically kind of a temporary pain relief and or diagnostic tool?
So these shots can be diagnostic if you just use a local anesthetic to numb up the area. And diagnostic meaning it will tell you if pain's coming from that area.
Okay.
And you'll get relief temporarily, but it's meant to give us information of where's the pain coming from.
Got it.
And it will treat the symptoms in that you could have a disc bulge or even a herniated disc and it not be symptomatic. So if you can take the inflammation away and take away their symptoms, well, then it does treat the disease, but you're really just taking away the inflammation and pain. The disc bulge is still there.
Got it. Okay.
So And so for the joints here, we can do things like nerve blocks.
Now, the nerve block, is that different medication than the steroid injection?
Yes, because these nerve blocks typically are just local anesthetic. That way you know if it's coming from the joint, so it's more specific. But then what you would do is you would go back and do a needle with electrical pulses, or some physicians in town will actually visualize the nerve and cut the nerve. But you basically destroy the nerve, because all it does is go to that joint, and that will give you longer lasting pain relief.
And y'all know, if you cut that nerve, it's not going to screw up and I'm going to be walking with a drop foot or anything.
100%. So there's a lot of testing and safety, because obviously the FDA would never approve it if that was the case. But there are bigger nerves further away, but you have to test first to make sure you're not near those. You can get some soreness at the site, things like that, localized infection, which are always risk of any procedure. But as far as that, it's extremely uncommon. And so, but that would give you longer lasting relief for more back pain. There's other joints down here. Part of the hip joint, the pelvic girdle, is this SI joint. It's a big joint, and it can also often be injured in accidents or just wear and tear over time with
So
arthritis.
the joints are basically the disc where the vertebrae or the disc is keeping the bones from rubbing on top of each other.
Yes.
The facet joints, the same thing. It's the transverse processes and the other, because the facet joint is actually two separate bones, right?
Correct. You would have the bone above, and then you would have the bone below making up the joint at level correctly right there. So this would be, if you did this one, this would be the L5 bone, this would be the S1 bone, so that's the L5, S1 facet joint.
And tell folks how you pretty much can pretty accurately figure out what nerve is hit before you go in there, and I assume it's by symptoms.
So it's by symptoms. There's been obviously tons of studies that will look at where these nerves go, and so you know the S1 nerve goes down to the big toe, the back of the leg, the L5 goes to outside the foot and down the leg, and they work their way up. So there's maps. I will say though, nobody's body has read the textbooks, so there will be there will be some variation. So you go with clinical symptoms, you'll look at the MRI reports, you'll look if they've had EMGs, you'll kind of put everything together to give you a more accurate picture. It's hard to go on just one finding to make a good study, because nothing's perfect.
And so you've got multiple ways of trying to narrow down where the pain is being generated, so you focus on that.
Correct.
And then if it doesn't do it completely well, then you're looking at other possibilities.
A lot of times, especially my older patients, they have multiple things going on. They'll have degenerative disc, they'll have arthritis, they'll have bulging disc, and you just have to talk to them, spend time with an exam and speaking to them. And what do you think is the main pain generating lesion? What would be the most efficacious and the less risky for them? Do they have diabetes to where they can't even have steroids? Have they had surgery before? So what would be the safest and most efficacious, knowing that there may be multiple things causing their pain?
So how do you treat the disc injuries?
The disc injuries, if it was a bulging disc, herniated disc, we typically start with therapy, anti-inflammatories. If it goes over time and doesn't improve, epidural steroid injections. If, again, it's still causing severe pain, ridiculous symptoms, we would say, hey, look, is this something where a surgeon may be able to decompress it, meaning get that disc off the nerve?
Right.
And if that's an option, great. If that's not an option, then we do more advanced techniques such as spinal cord stimulators or even pain pumps down the road.
And I want to talk about both those. How when you're giving these injections, I mean, let's face it, you're getting in deep into the body and very important area, where your cord is and your nerve root. So how do you know that you're not hitting something wrong or heading through the wrong structure?
So one, you're doing these injections under X-ray now, and so you know kind of what level is safe to go at what depth. But with X-ray, you're also using a little contrast to make sure you're in the right space. You're also having the patient under what's called conscious sedation or no sedation. So it's not general anesthesia. If they're under general anesthesia, they can't respond.
Right.
If you were to get close to a nerve.
But if you hit that nerve
under conscious sedation, they're going to feel it, which is it's a safety mechanism. Now we give them a little what's called Versed. It's an amnestic, so it makes them forget. So most times they will not remember. But it's a little bit of a safety mechanism to keep them a little bit awake.
And so is it your choice or is it the patient's choice as to whether or not they go completely under, or you want them awake enough to be able to know if you're hitting a nerve or something that doesn't seem right?
There's a couple procedures we'll do where we don't want to give them any sedation because we want them to give accurate representation of what they're feeling. So for instance, there's a procedure where if a patient has bulging or herniated disc and they have multiple and we want to find out which one's a problem, we'll keep them awake and we'll put a tip of the needle in the disc and we'll replicate pressure on the disc by putting contrast in there. And we want them to be able to tell us what that feels like, so we don't sedate for that. But usually it's up to the patient.
All right, well, we'll continue this on the next segment where we get into the little more invasive processes. It's Locke Meredith with Dr. Alan Johnston, pain management doc and doctor of anesthesiology. We'll be right back. Locke Meredith, Sean Fagan and Associates has served our community by airing Legal Lines, a community educational program for 18 years weekly to Baton Rouge and the surrounding areas. Watch Legal Lines at LockeMeredith.com or Cox Channel 1004.
Hello, my name is Sean Fagan. And you know, one of the most important considerations in hiring an attorney is considering trust. I believe at our firm, our results speak for themselves. Most of the people we represent come from past clients who have referred friends, family members, other people they love to us to represent them in the same way we represented the persons who referred them. It's the greatest compliment any law firm could get. And I believe that if you come to our firm, we'll earn your trust.
Legal Lines has interviewed Louisiana Supreme Court justices, appellate trial court judges, federal, state, and local government leaders, including U.S. senators and Congress members. Watch at Locke Meredith, Sean Fagan and Associates website, LockeMeredith.com or Cox Channel 1004. Welcome back to Legal Lines. I'm Locke Meredith again. Very pleased to have on the show Barrett Johnston. I erroneously referred to him as Alan in honor of his dad.
He's awesome. I'm okay with that.
Agreed. All right, let's shift gears a little bit. You were talking about the injections and where you put the needle and what it is you're trying to accomplish.
Yes.
And it's both diagnostic, but it also can reduce the pain and hopefully possibly eliminate it for a long period of time.
Yes, sir.
Now, you've talked about those processes. Isn't there, I call it a radio burn, where you're going in, and I've actually had it 4 times. Tell folks about that.
Yes, sir. So you can do what's called a radiofrequency lesioning or ablation, commonly referred to as burning of the nerve, for these joints in the lower back called facet joints. And what you're really burning or lesioning is the little median branch nerve that just goes to that joint. And what you do is little electrical pulses through the tip of a needle. So you insert a needle or probe, and then the tip of that does an electrical pulse to that nerve. It deadens the nerve. Unfortunately, the nerve does regrow. Textbooks say 3 to 4 months, but patients do get longer lasting relief than that quite often. And so insurance companies will let us repeat about every 6 months. But it's really, if the patient's symptoms return, well then you know that nerve has regrown and you could technically do it then.
Now, as I understand it, you can also actually do the rhizotomy where you're going in and cutting the nerve?
Absolutely. Yeah, so there's some physicians in town, they'll make a small incision and they'll visualize that nerve and they'll get a complete transection of that nerve. It's a little bit, you're more successful at cutting the entire nerve, and so the results last a little bit longer, and it takes a little bit longer for that to grow.
But it still regenerates, the nerve eventually. So these are temporary fixes in all likelihood. Okay. All right, well, let's shift gears now to the little more invasive stuff.
Okay.
And tell me about, I call it the external TENS unit.
Yes, great, yeah.
Because tell folks what a TENS unit is and then what this is doing.
So a TENS unit is the devices you'll get early on in the treatment. It goes on the back, it uses electrical pulses, stimulation, even muscle stimulation to kind of provide pain relief on top of the skin, goes through the skin to the muscles and nerves.
Kind of like those shock collars that you see dummies do, shock themselves and all that.
What we do to the kids.
Yes.
Just kidding. So what we're talking about today is a spinal cord stimulator. So it's a similar technology, a lot more advanced, to say it that way, but it's an easy way to explain it is you put something along the nerve roots or the spinal cord to kind of block those nerves from
So is it touching the nerve roots?
Yes. So what happens is you'll insert an epidural needle into the epidural space through the needle.
And that's one of the devices right there?
Yes, sir. This would be the device. This would be the permanent device.
Okay.
You actually have to do a trial first, which is great because you want to know if it's going to work. And so basically the trial is done just like an injection. You put the epidural needle in, the lead, which is just the size of a spaghetti noodle, nothing.
Like a wire, just a wire, huh?
Just goes into the spinal canal and goes up and lays on top of the spinal cord above where the problem is in the lower back. And what it does is...
You said by the cord, we're not talking about the nerve roots now, we're talking about the cord?
The spinal cord, well, there's new technology, as mentioned before, that will actually go along the nerve roots this way for joint pain, hip pain, knee pain, ankle pain, and it's great for that. But for most often we do it for back pain, leg pain, neck pain. And you can program the little electrodes to block certain nerves from sending the pain signals. And what it does is just cause a traffic jam. You put so many signals, or electrical pulses, that the nerve can't send that pain signal to the brain.
And it's just touching the cord. It's not actually
If you
embedded
want to
in
know
it.
specifically, it's in the epidural space, which actually sits on top of the dura, which is a water balloon covering, and then the spinal cord.
So it's like a conductive.
It's close. It's really
Wow,
close.
that's so
But it's never-
interesting.
and so it's amazing. And
Any
so,
complications from this?
anytime you break the skin, there's always a chance of bleeding and infection, and so you have to watch for that. So yes, there can be, but it's extremely safe, and we have not had any yet.
So there's really that no one said my cord's getting stabbed or whatever. And
No, sir. And so what happens is, so that will go in, and then the back side of this for the trial period just tapes to the back. For a week, they use it like a real device. So you walk around, do your normal activities, and what we know is this improving their quality of life? Are they feeling better, more active, less pain, taking less medicine?
Fascinating
Then
stuff.
it just slides out. So there's no cutting or incision with that. If it works well, then we have a battery here. There's several kinds of batteries now. You make an incision for the battery, incision for the leads, everything's underneath the skin. Once incision healed within a couple weeks, you're going about your normal life. You can swim, bathe.
And
get
where
MRIs.
are you typically implanting the device?
This battery will go usually in the buttock or back. We can put it in the abdomen as well, just depending on the patient's body
What is
habits.
your preference? Is there a preference for you, or it doesn't matter?
Doesn't, whatever the patient's preference is, and it depends on their lifestyle. If you sleep on the right side, we'll put it on the left side.
Interesting.
If you don't have much room in your back, I'm gonna put it in the front. So no, my preference is whatever's good for the patient. And so, but once it's in there, you're going about your normal life. You're usually taking less medication, being more active. There's settings now where you can either feel the buzzing or sensation,
Right.
or you can feel
Well, that's the
nothing.
way I use it. I'd turn mine all the way up when I was in so much pain.
But
It
back
just-
then, but now technology's gotten so good, you can turn it up and you don't even feel the buzzing. It just relieves your pain.
Really?
It's amazing. Yes.
Fascinating. And so, how do you control the device if it's inside your body?
So, of course, with the iPhone, just like everything else in the world,
iPhone.
I think it's actually an iPod,
Yeah.
and so you can make it do your. Say you did it for your low back and legs, you could do just your back. You could get both legs covered, just your right leg covered, just your left leg covered. You have multiple
Fascinating.
programs with the same device.
Now,
in you.
now, does one lead cover multiple vertebrae area? Or?
Yes, sir. It covers two so what you're more worried about is what part of the spine the spinal cord does it cover. If you can imagine, your spinal cord covers all the nerves that go to the brain. So from the thoracic spine where we push this lead, all the nerves that go from the lower back and legs must pass that area. So all the nerves are going through there. So you can cover all the lower back and all the
Now,
legs
how
by
do you
putting it in the
know,
middle back.
with all the nerves that are in the cord, which one is the pain generator? That's the trial and error?
Well, through studies, you know that the pain nerves are in the posterior part of the spinal cord, so that allows the coverage. If you were to put the spinal cord lead in the front of the spine, you would get more motor stimulation.
And
so I'd make the legs jerk, things like that.
Right.
Extremely
Okay.
uncomfortable.
So there's no chance of that interfering with motor skills, or
No, not unless you
or,
would have to turn it up to a high level that'd be so uncomfortable they wouldn't tolerate it.
Okay.
Yep.
Okay. So the way that it's safe is you know where the nerves are in the cord.
Yeah, and then
It's in
you're
the back.
testing to make sure that you get the exact coverage that they need while they're on the table before they even go home the first time.
All right. Now, what about the pain pump? I've heard that actually came before this, didn't it?
Yes, sir. That's been around a very long time, and that's another great device. It is about the size of a hockey puck, is what I tell patients.
Last question on this
Oh, go ahead.
this internal TENS unit.
That's right.
How long does the battery last?
Battery lasts about 5 to 7 years.
Really?
It honestly depends on how much you use it. Sometimes people will have it cranked up using it a lot. It's a little less, sometimes a little bit more, but we typically say about 5 to 7 years. Super easy to replace it. All you do is like change on a battery. You make an incision, take the old one out, put a new one in. It's an outpatient. These are outpatient procedures as well.
And
They're
so
not sitting in the hospital.
after it's done, you feel it up after a couple of weeks. You can hike, you can swim, you can do anything you want. There's no limitation, physical limitation,
There's
or restriction.
no, as much as you can tolerate, but there's no limitations as far as what you can do with this thing inside. You're swimming, you're living your normal life, and that's the goal, is to improve function with everything we do.
So fascinating. All right, and
It's
so the
amazing.
pain, this is basically stopping the pain or minimizing it with electrical impulses.
Yes.
What's the pain pump doing?
So the pain pump is the idea of putting the medication directly where the problem is. So you do a trial, it's a single shot trial, but more important is a permanent implant. It's about the size of a hockey puck that's a reservoir for medications that will deliver medications directly into the spine where the problems are with the nerves. And you can put different types of medicine there, medicines that you can't take by mouth. There's
Fantastic.
much less side effects. It's a great option for
Thank
people.
you very much. I appreciate
sir.
it, Barrett. This is Locke Meredith with Dr. Barrett Johnston. We'll see you next time.